Erector Spinae Plane block. Cervical, thoracic, lumbar, and sacral erector spinae plane block. This is another video as part of my course to cover the truncal region analgesia, which contain the following blocks. For each one, I have a video, and there is a long video lecture that goes after the fundamentals of the truncal region analgesia, mainly covering the anatomy and mechanism of action. So I hope you got excited or interested or brought your attention when I said on the title cervical, thoracic, lumbar, and sacral erector spinae block. How come? Well, if you look at the erector spinae muscle, that basically consists of a group of three muscles: the spinalis, the longissimus, and the iliocostalis. And you look at this muscle and you will see it extending from the occiput all the way down to the sacrum. Although when it comes to the sacrum, it's more an aponeurosis. However, it's a very long muscle along the back. And the way this muscle named, so the neck obviously is capitis, the chest is the thoracis, and the lumbar is lumborum. So you will see the same muscle changing its name based on the region. So in the neck, you will see spinalis capitis or semispinalis capitis. In the thoracic, you will see spinalis, thoracis, and etc. Now, let's start by the cervical erector spinae plane block. So, to understand how this is working, let's take a step back and talk about the fascia in the neck, which I covered in the first lecture. So in the neck, we have two main fascia, superficial and deep. But the deep consists of three layers. The investing, which is the most superficial, the yellow one here. Then underneath that, you have the pretracheal, which is the middle. This is in front. More relevant is the prevertebral, which is the deep one here in the dark purple color. So if you look inside this prevertebral deep fascia, here in this picture, for example, it's more clear. So again, if you trace this all the way, you will notice that the anterior, middle, and posterior scalene is here. And what we have between the anterior and posterior, the middle, the brachial plexus. And then at the end here, we have the erector spinae muscle. And here we have the levator scapulae muscle, and it changes as the level goes. But just so this will explain a lot of application for this technique. So how we do the cervical erector spinae block, either in sitting or lateral decubitus position, use a linear transducer, and it's the whole block take about 20 mil. So the target will be the posterior, the lateral posterior edge of the transverse process of C6 or C7 or both. And the needle will travel through the trapezius and levator scapulae muscle. The anatomic component of the erector spinae muscle group at the cervical area include semispinalis cervicis, longissimus cervicis, and iliocostalis cervicis, which arise from tendons attached to the posterior tubercle of the C2 to C6 transverse process. To adequately provide analgesia to the brachial plexus, which is in front, as I showed you, and I will show you the next slide, the erector spinae block need to be performed at the lateral tip of the cervical transverse process, lateral to the semispinalis cubitus muscle. This location is closest anatomically to the brachial plexus because the only separation is the thin middle scalene muscle. If you go more medial and posterior, then you will get the multifidus cervicis plane block or semispinal block, also known as cervical paraspinal block, which is more selective to the dorsal rami of the cervical spinal nerve. So this is what I was talking about. Here we'll see the erector spinae muscle, and here you have the middle scalene. That is the separation between this approach and the brachial plexus. So you put your needle in this orientation and you go to the lateral tip of the TP, transverse process, and you will transect the trapezius and levator scapulae. Now, if you go more medial, obviously, so this is the ventral branch, this is the dorsal branch. If you go more medial, like here, you will have different plane block, which is the multifidus cervicis and the semispinalis plane block, which again, now we are selective to the dorsal root. So again, to get the ventral root, to get the brachial plexus, you have to go lateral to the transverse process. So how we do it? Now at C5, first, this is the orientation of the probe, as you see. Some tilting and some angulation, and we are looking, this ultrasound correspond with this view angle of the cervical vertebrae, and we are coming from posterior to anterior, as you see the green arrow here, aiming to the posterior tubercle here. So here we are crossing the longissimus cubitus and putting our medication here, so it will also spread along the middle scalene and reach C5. Now, when we go slightly lower to C6, here you have the posterior tubercle and the anterior tubercle, and again you aim here and hopefully the medication will spread to the brachial plexus and back to the other branches. Then you go lower, the vertebrae here is slightly different, so C7, as you see, the C7 root is dropping into the intervertebral foramen, and it's slightly different. So here you have the TP again to this area, so it can spread alongside the middle scalene. Now, here is a short clip So as you see, this is the 2E needle touching the TP lateral, injecting the medication, and the medication, as you can tell, it's spreading anterior also, and it is going underneath the middle scalene and reaching to the anterior compartment, so it's reaching the brachial plexus, and some of the medication also I see going back to cover the dorsal root. So when what nerves we are blocking here? So ultrasound guided cervical at C6 and C7, it should cover a sensory level from C5 to C8, the root of the brachial plexus and the dorsal rami, as long as the long thoracic, dorsoscapular, and suprascapular nerve. Indication, this is a new block, so potential indication include shoulder surgery and cervical spine surgeries. It's still new, it's under investigation, and more research needed. For chronic pain, potential use is radiculopathy, and then contraindication, general contraindication as any other block, and side effect or complication, again, last, interestingly, phrenic nerve involvement. So this is a small study, 10 patients, 3 of them, they get phrenic nerve involvement in the cadaver study, and also potentially vertebral artery injury. So let's shift gear and talk about thoracic erector spinae block. This should be easy. So in the sitting position or prone position, sitting probably easier, use a linear transducer, and often performed between T5 and T7, mostly at T5. So scan parasagittal, paramedian, identify the TB. Then once you verify that, there will be the trapezius rhomboid muscle. If you are performing the block at T5 and above, you will see the rhomboid. Below that, you should not see the rhomboid. And then the erector spinae underneath that, and your needle advanced superior to inferior in plane, so cephalic to caudal. And once the needle tip below the erector spinae, touch the TP, give a small bolus, and then the erector spinae muscle should be visualized separating from the TP, then inject 20 to 30 mil. You can track that as well, and don't forget to aspirate every 5 mil, and you will see the classic movement of the erector spinae, which is called the breathing sign. You also can put a catheter in this place. So very simple. If you start scanning from lateral, if you see the rib, that means you are too lateral. If you see the lamina, that means you are too medial. So you have to see the TP and the rib underneath there. And again, this is your target here. Again, see the orientation coming from cephalic to caudal, and touching the TP, withdraw a little bit to see the separation of this layer and the breathing sign. What nerve we are blocking? Dorsal and ventral rami of the spinal nerve, spanning 1, 2, 3 levels, cranial and caudal to the level of injection, and there is some potential spread to the paravertebral space. Indication: analgesia for ribs, back surgery, breast surgery, chest wall procedure like NAS procedure. Contraindication, like any other general contraindication for these type of blocks, and complication: pneumothorax, hemothorax, infection, bleeding, and last. Now let's talk about lumbar erector spinae plane block. This is more technically challenging, like the cervical. So patient in prone position or lateral decubitus position. Now we're going to use the linear curvilinear transducer because we're looking at the deeper structure here. So this is a parasagittal ultrasound view at the L3 and L4. Um, uh, these are the L3 and L4 transverse process. The erector spinae, as you see, it's above, clearly visible. Then you also can see the medial edge of the quadratus lumborum adjacent to the tip of the transverse processes. And there are two obvious facial plane here. One is between the erector spinae and the quadratus lumborum, which is this, and one between the quadratus lumborum and the psoas muscle. While if you look at the transverse oblique, so basically you put your curvilinear probe transverse and you tilt it, so you get this oblique view. This is at L3 level. Again, you see the facial plane between the erector spinae and the quadratus lumborum muscle here, and between the quadratus lumborum and the psoas muscle here. The two planes converge at the medial edge of the quadratus lumborum muscle and erector spinae muscle. And your target will be the articular process, as I will show you in this slide. So when we do lumbar erector spinae block, there are at least four reported approaches. The parasagittal, which is the one I prefer. I think it's the easiest one. So this is how you place your ultrasound probe. So, and then you move lateral until you see the TP. And as you see the TP here, you come in plane and same thing, touch the TP and wash the erector spinae separating, like the breathing sign we saw in the thoracic level. The second approach is the transverse approach. So your transducer is in transverse, and this allows the dorsal structure of the vertebrae to be visualized simultaneously. Both in plane and out plane can be done. So this is, for example, an example of out of plane. The needle is coming out of plane here to touch the TP and injecting the medication. The third approach is the transverse subcostal approach, also known as ACOSU approach. It allows for the application of the block in the lateral position under general anesthesia. The disadvantage of this technique is the poor visualization of the local anesthetic, but it is easier to perform in the pediatrics. So see this patient in lateral position, and this is your ultrasound orientation, and you're seeing the TP here. The last approach is the Tolgar modification, which basically it's the parasagittal plus, which is here, that we know that, plus a second injection that go deeper between the transverse process and the psoas major muscle. And the idea by doing that you can cover the lumbar plexus. So it's 2 in 1 if you wish. The nerves that are blocked, the dorsal and ventral rami of the spinal nerves, spanning 1 to 2 level cranial and caudal to the level of injection. However, cadaver studies show inconsistent spread in the lumbar region. And so this is probably not very popular block. However, there are some studies. So for example, this is a single center, it's not a clinical trial, found that lower thoracic erector spinae block, when performed at T10 and T11, might be a better option for total hip arthroplasty, and can be substituting the fascia iliaca catheter with erector spinal catheter at this level, and it should increase amount of ambulation. But again, this is not a clinical trial, but this is a potential use here. So indication: lumbar spine surgery, hip surgery, prostatectomy. Contraindication, like general contraindication for these blocks, and complication: motor weakness. It's a side effect because you are close to the lumbosacral plexus. And bleeding and infection. Finally, let's talk about the sacral erector spinae plane block. So this is an injection of local anesthetic and retrolaminar L5 and sacro-retrolaminar on the desired side. This will spread to the ventral rami. Another paper described this technique as injecting local anesthetic between the multifidus and the intermediate crest that lies immediately medial to the sacral foramina in the interfacial plane. Some authors even call this sacral multifidus plane block. So it potentially can spread up to the lower lumbar, and it is an interfacial block for the sciatic and pudendal nerve. So it can cover the sciatic and pudendal nerve. Indication: there are some reported uses for still case reports, still early to judge. Postoperative analgesia for sacral fracture looks attractive here. An inferior clonal nerve entrapment for original description. Anoplasty looks another attractive implication here. Possibly every indication of caudal block, and for chronic pain, possibly or potentially for S1 radiculopathy. We still need to see more studies, but this looks promising, and it is also easy to perform. So here you have the needle at the S1 level, and as you see, you don't want to go into the foramen here, so he pulled back a little bit to see the separation of the muscle. So this is what you would like to see. This is the classic separation here. Okay, thank you for watching.